Hello, friends. Today we are going to discuss the corticosteroid induced insufficiency. It is the most common condition encountered in the ICU, and also it is also the question which was asked in DRNB critical care exam. So, critical illness encompasses the diverse range of severe conditions that require advanced organ support in intensive care unit and has estimated prevalence of 45 million cases annually. A proposed definition of the critical illness is the state of ill health with the potential for reversibility characterized by the vital organ dysfunction and high risk of imminent death if care is not provided. So, the duration and the severity of the critical illness are determined by its etiology, which include systemic inflammatory response syndrome, compensatory anti inflammatory response syndrome, cytokine release syndrome, and acute respiratory distress syndrome, multiple organ failure, and persistent inflammation, immunosuppression, and catabolism syndrome. So, critical illness corticosteroid insufficiency is characterized by adrenal insufficiency due to impaired functioning of HPA axis, altered cortisol metabolism, and tissue corticosteroid resistance. So, this results in exaggerated prolonged pro-inflammatory response, especially in ICU patient in whom there is incidence of the CC varies widely, which ranges from 0% to 30%. In specific populations such as those with septic shock and trauma, the incidence can be as high as 25% to 40% and 50% to 70% respectively. In addition to elevated 28-day mortality rate compared to non-CRC patients, a mortality rate of 34% among post-trauma CRC patients was reported. Non-survivors were old, that is 65 years or older, and had more severe base deficit at admission, required prolonged ventilatory days, and had increased rate of sepsis, bacteremia, and pneumonia. So, CRC is the common and complex phenomenon, understanding of which is evolving. A study conducted in 2021 examined medical practitioner approach to CRC management, and 72% of respondents reported having to address CRC at least once in a week. However, utilization of the former protocol for CRC diagnosis was limited, and notable proportion of practitioners forego lab testing for this purpose. However, substantial majority express uncertainty regarding the therapeutic role of corticosteroid in CRC cases. Therefore, given the CRC prevalence in the various critical conditions, medical professional education on its pathophysiology and treatment is imperative. So, let's try to understand the pathophysiology of this condition. Critical illness elicits the significant physiological stress response, promoting the body to activate various mechanisms to maintain homeostasis. One crucial mechanism involves heighten the activity of HPA axis, which rapidly increases systemic glucocorticoid levels that are essential for survival. So the classic model describes that stressor in critically ill patient consists of neuronal and inflammatory signal that act on hypothalamic nucleus, that is paraventricularis, to release corticotropin releasing hormone and arginine vasopressin. So the CRH and AVP are transported to the anterior pituitary to trigger the release of ACTH into systemic circulation from corticotropic cells. Under the influence of ACTH, the adrenal gland synthesizes the glucocorticoid, mineralocorticoid, and adrenal androgen from the cholesterol. Then cortisol then exerts its systemic effect on numerous cells and modulate inflammation, cardiovascular function, and metabolism. However, in recent years, this traditional model has faced the scrutiny, and it has been shown that elevated cortisol level in critical patient does not necessarily coincide with high concentration of plasma ACTH. So, pathophysiology behind this CRC is the dysregulation of the HPA axis, altered cortisol metabolism, tissue resistance to the glucocorticoid that are thought to be there uh, that are thought to be three main pathophysiological events in the cells. So we'll see it again. So the main three pathophysiological events in CIRSE is dysregulation of HPA axis. That means our here this hypothalamo-pituitary adrenal axis won't respond properly to the stress which are produced in the body. Then second is altered cortisol metabolism. That means there won't be any proper response to the increased corticosteroids, cortisol level. And third will be tissue resistance to the glucocorticoid. Now we'll see the pathophysiology of the CIRSE in detail. So how this HPA axis dysfunction will contribute to CIRSE? So the classical activation of model of central HPA axis is characterized by elevated ACTH level driving high and adrenocortical cortisol production in response to sepsis and critical illness. An increase in plasma ACTH has only been observed temporarily in the critically ill patient, after which at least during initial week in ICU, plasma ACTH is consistently maintained below normal level. A recent research indicates that patients who spend 4 weeks or more in ICU many experience suppression of HPA axis that resemble the central adrenal insufficiency. When HPA axis stress response becomes dysregulated in intensity or duration, the equilibrium is disrupted, leading to CIRSE. So detrimental effect on fundamental bodily process such as growth, metabolism, circulation, reproduction, immune response, cognition, and behavior follow. So disruption of this HPA axis during stress also affect the mitochondrial function, comprising their vital role uh, in energy production, synthesis of lipid, heme, purine, steroid to exacerbate metabolic disturbance. So under the condition of severe stress and responses, typically deemed adaptive may prove to be inadequate or even detrimental. Then altered cortisol metabolism and negative feedback inhibition. So the regulation of cortisol production due to critical illness is complex and it involves the intricate interaction among CRH and ACTH pathway, autonomic nervous system, vasopressin system, and immune system. This includes disruption of normal circadian rhythm of cortisol secretion due to rapid ACTH release via CRH and AVP mechanism. Initially, there is reduced cortisol breakdown in the liver and kidney during critical illness. This attributed to suppressed expression and activity of cortisol metabolism enzyme with extension of cortisol half-life and hypercortisolemia. Additionally, the cortisol is released from plasma binding proteins, transcortin and albumin due to decreased hepatic synthesis of and decreased cortisol binding to this protein. However, although there is initial activation of pituitary glucocorticoid receptor and increased circulating availability of the free cortisol, this eventually results in impaired processing of pro-opiomelanocortin into ACTH and decreased secretion of mature ACTH. This response is due to negative feedback loop via expression of annexin A. So this negative feedback inhibition at pituitary level may also involve binding free cortisol to glucocorticoid receptor or binding of other ligand of glucocorticoid receptor such as bile acid. So the reduced expression of the enzyme prohormone convertase 1 during sepsis also contribute to the decreased conversion of POMC into ACTH. Now the third mechanism is tissue resistance. So CIRSE mediated by tissue resistance to the glucocorticoid. A transient increase in the expression of glucocorticoid receptor beta is present in the mononuclear cell from septic patient and is accompanied by simultaneous increasing dominant negative GR beta expression. Additionally, serum obtained from septic patient induces glucocorticoid resistance in cell culture, suggesting potential mechanism for cell level resistance to the glucocorticoid in sepsis. Further, sepsis is characterized by the declining glucocorticoid receptor alpha level in circulating liver and muscle tissue, with reduced GR alpha transcription in various tissues, including circulating lymph nodes, spleen, liver, kidney, lung cells, and tissues. So, this reduction in GR alpha is paralleled by increase in expression of GR beta isoform, leading to imbalance between GR alpha and GR beta. Moreover, glucocorticoid therapy induces expression of mitochondrial receptor 124, which downregulates GR alpha and limits the anti-inflammatory effect of glucocorticoid. This observation suggests the steroid treatment may exacerbate glucocorticoid resistance, particularly in patients with elevated GR beta. These imbalances in GR alpha and GR beta expression are associated with increased sickness sensitivity and reduced glucocorticoid sensitivity, both of which contribute to the corticosteroid resistance at tissue level. Then drug-induced cells. Certain medication administered during critical illness, including glucocorticoid, opioid, azole antifungals like ketoconazole, and psychoactive substances, can potentially suppress the synthesis of ACTH. Administration of exogenous glucocorticoid exerts the negative feedback control on HPA axis by suppressing the production of the CRH in hypothalamus and ACTH secretion in pituitary gland. This suppression leads to hypertrophy and atrophy of adrenal cortex, leading to significant decrease in the cortisol production while maintaining mineralocorticoid activity. Consequently, this results in adrenal insufficiency, with adrenal gland becoming incapable of producing sufficient level of cortisol after cessation of the glucocorticoid therapy. Abrupt cessation and rapid withdrawal of glucocorticoid therapy may precipitate symptoms of adrenal insufficiency. Opioid may induce adrenal insufficiency in similar fashion by primarily inhibiting the HPA axis at the level of hypothalamus, decreasing cortisol production. Benzodiazepine contribute to the rapid decline in cortisol production by inhibiting function across the various central and peripheral points of HPA axis. This point includes the activities of adrenal microsomal 17 and 21 hydroxylase and 11 beta hydroxylase in adrenal mitochondria. Administration of etomidate inhibits the final enzymatic state in cortisol synthesis and markedly increases the likelihood of adrenal insufficiency at both 4 to 6 hour and 12-hour post-administration in critically ill patients. Ketoconazole and imidazole antifungal medication and treatment option for Cushing syndrome targets and inhibits crucial enzyme in adrenal steroidogenesis. So acute adrenal insufficiency also has been observed in patients treated with fluconazole, another antifungal agent, especially among those who are critically ill. So this is the pictorial representation of pathophysiology behind the scenes. So as you can see in the picture, the first mechanism is dysfunction of the HPA axis. That means if during the early phase of the critical illness, this stress response will stimulate hypothalamus and pituitary gland to release the ACTH. That ACTH will causes the stimulation of adrenal to release the cortisol. But after the 4 weeks of the critical illness, this stress response will become inappropriate and it will cause the suppression of the adrenal. So there will be, so after 4 weeks of the critical illness, there won't be there won't be the proper stimulation of this hypothalamus-pituitary axis, and there won't be secretion of the ACTH, and the cortisol level will decrease. Then the second mechanism is there will be the decrease peripheral peripheral production of the cortisol, and also the sepsis will cause the peripheral resistance to the cortisol. So body will persist it as the so there will be the lack of negative feedback mechanism to the production of the ACTH, and that will produce the adrenal insufficiency. Third mechanism will be, if there is resistance to the glucocorticoid receptor, there won't be again the same mechanism will be involved, that is the negative inhibition to the ACTH, and there will be the central adrenal insufficiency. The fourth mechanism will be the drug induce. So few drugs will cause few drugs will inhibit the production of the uh, few drugs will inhibit the production of the steroid hormone in the body, which will produce the CIRS. Now about the presentation and the diagnosis. CIRS in the context of the prolonged critical illness poses the significant challenges in the diagnosis due to overlapping signs and symptoms with expected critical illness, critical courses in this patient. So, these signs and symptoms include fatigue, weight loss, syncope, fever, confusion, somnolence, back, leg cramp, postural dizziness, and hypotension. In severe cases, there will be hypovolemic shock and coma. Features such as encephalopathy, poor neurological recovery after sedation cessation, persistent need for vasopressor should raise the suspicion of CILS. Additionally, a reduction in the adrenal gland volume to less than 10 found in some patients with septic shock and has been linked to the increased mortality. The Endocrine Society advises the stimulatory testing for cortisol deficiency in suspected primary adrenal insufficiency cases. Confirmation of primary adrenal insufficiency typically involves morning cortisol level lowered by 250 microgram by synapse stimulation test. The ACTS measurements aid in the distinguishing primary and secondary and or tertiary adrenal insufficiency. If ACTH level is more than 66 pmol, then it is suggestive of this primary adrenal insufficiency in patient with confirmed hypocortisemia. So, stimulatory testing using both low and the high synthacan doses aids in the diagnosis. So, simultaneously, renin and aldosterone measurement is recommended in mineralocorticoid deficiency confirmation. Then, secondary adrenal insufficiency diagnosis involves dynamic stimulatory testing, insulin tolerance test, and it is a gold standard for this. American College of Critical Care Medicine suggests considering adrenal insufficiency in patients with rapid random cortisol of less than 10. However, diagnosis of CERCI is more complex. While low random plasma cortisol concentration may raise suspicion, there is no clearly established guideline for definitive CERCI diagnosis. Critically ill patient requiring mechanical and pharmacological support in ICU for 4 weeks to longer, especially those with hemodynamic instability, despite adequate resuscitation and vasopressor support, should be considered at diagnosis of CIRS. Furthermore, exposure to medication that affect HPA axis and cortisol synthesis should heighten the suspicion of CIRS. Lab finding in the CIRSE may include hyponatremia, elevated creatinine level, normo, normo, normo chromosomia, then lymphocytosis, eosinophilia, hypoglycemia, and hypercalcemia. Patient with the CIRSE may also exhibit normal or the low cortisol level, low albumin and cortisol binding globulin level, normal or low ACTH level, and high bile acid and bilirubin level. Elevated inflammatory cytokine levels, such as those For tumor necrosis factor, interleukin 1 beta, interleukin 6 at ICU admission and throughout the ICU stay correlate with the disease severity and increased mortality risk. A total serum cortisol of less than 9 microgram per dl post ACTH stimulation or random total cortisol of less than 10 microgram per dl was considered reliable for diagnosis of adrenal insufficiency in critically ill patients according to 2008 task force guideline by American College of Critical Care Medicine. However, these criteria were not widely adopted in the clinical practice, and recent guideline updates in 2017 do not include the use of this specific test. Instead, Endocrine Society confirmed high dose, that is 250 microgram ACTH stimulation test is superior to the other tests such as plasma and serum free cortisol, salivary free cortisol, low dose ACTH stimulation, and hydrocortisone level and corticotropin level in diagnosing CLC. So, peak plasma cortisol level of less than 18 microgram per dl at 30 to 60 minutes or high dose ACTH stimulation is confirmatory in diagnosing CLC. So, despite this suggestion, new pathophysiological evidence of CLC has had diagnostic implications. For example, the increase in distribution cortisol volume and suppression of cortisol binding globulin have invalidated the use of classic 250 microgram ACTH stimulation test. Due to these pathophysiological changes, the stimulation test results in confounded as incremental response of total plasma cortisol to the ACTH injection is suppressed. Although the ACTH stimulation test cannot be used as a marker of adrenal insufficiency, low cortisol response does reflect the increased severity of the illness. So, random total cortisol concentration are also unlikely to provide useful information to clinicians for diagnosis uh, as they vary widely between patients and even single patients. Additionally, specific imaging techniques like bedside ultrasound, computed tomography, magnetic resonance imaging can assist in diagnosing CIRSE by distinguishing it from the rare complication of critical illness such as adrenal hemorrhage. Although there are many findings that suggest the diagnosis, there is no single diagnostic test or imaging technique to reliably diagnose CIRSE. When diagnosing CIRSE in critically ill patient, a comprehensive approach that considered clinical presentation, lab finding, and dynamic stimulatory testing is required. Acknowledging the challenge imposed by altered cortisol dynamics and the evolving understanding of CIRSE pathology also are required. A better understanding of presentation and diagnosis of adrenal insufficiency in critically ill patient can help clinician manage the patient effectively and improve outcome. Now about the treatment. Once CIRSE is accurately diagnosed, treatment with the intensive medical care and hydrocortisone is recommended. However, the exact hydrocortisone dose that is needed to manage CIRSE and prevent mortality is uncertain. Traditionally, the recommendation was to administer doses ranging from 200 to 400 mg per day to critically ill patient in ICU. This equivalent to approximately 10 to 20 times standard substitution or replacement dose. An assumption behind this was that those would meet the daily cortisol requirement necessary to generate and elevate plasma concentration associated with severe stress in healthy HPA axis individuals. 2008 study by Marek et al. Recommended hydrocortisone management regimen for cysteine septic shock. This recommendation was to administer 200 mg per day hydrocortisone in 4 divided dose or continuous infusion at a rate of 250 mg per day for at least 7 days in case of septic shock. The study also recommended methylprednisolone at a daily dose of 1 mg per kg of total body weight for at least 14 days, especially for patients with severe early ARDS. Gradual glucocorticoid tapering rather than abrupt discontinuation is necessary. If symptoms of sepsis, hypotension, worsening oxygenation recur, treatment should be reinstated. Dexamethasone is not recommended for the treatment of cirrhosis. In 2017 study, these guidelines were updated by multi-specialty task force of 16 international experts in critical care medicine and endocrinology. Their recommendations were based on evidence cited in 2008 study and more recent findings from the updated systemic review. The recommendations were formulated using grading of recommendation assessment, development, and evaluation methodology and required approval by 80% of the task force members. This study further emphasized the need for individualized approach that considers the patient's presentation, etiology, vital sign, responsiveness to vasopressor, and fluid in various critical illness conditions. For patients suffering from septic shock and not responding to standard treatment, such as fluid resuscitation and vasopressor, intravenous hydrocortisone at a dosage below 400 mg per day for minimum of 3 days is recommended. A 2018 study found that hydrocortisone plus fludrocortisone regimen resulted in lower 90-day all-cause mortality compared to placebo in patients with septic shock. For patients with the early moderate to severe ARDS, IV methylprednisolone at a dose of 1 mg per kg per day is suggested. For patients hospitalized with community-acquired pneumonia, corticosteroid for 5 to 7 days at daily dose less than 400 mg IV hydrocortisone or its equivalent is recommended. Corticosteroids are also recommended for patients with bacterial meningitis and those undergoing cardiopulmonary bypass surgery. In the context of cardiac arrest, the use of corticosteroid is suggested. However, the caution is needed when using corticosteroid in cases of major trauma and in adult patients with sepsis without shock. Several trials have shown no clear benefit in this case, and the risk may outweigh the benefit in such a patient. So, corticosteroid should not be administered in patients with influenza. In 2022 study by Teblik et al. Proposed more generalized approach for managing CRC, advising daily hydrocortisone regimen of 60 mg split into IV bolus, like 40 mg in morning and 20 mg in evening. This replicates normal diurnal rhythm that is disrupted in critically ill patients. So once corticosteroid treatment for CRC is initiated, administration should be tapered to the lowest effective maintenance dose. Discontinuation of medication should be achieved as soon as possible. The administration of corticosteroid in critically ill patients is associated with significant adverse effects that necessitate careful administration. This include hyperglycemia due to disrupted glucose homeostasis, hypernatremia, and fluid retention from altered renal function, and had susceptibility to the nosocomial infection due to immunosuppression. Corticosteroid use has also been linked to the neuropsychiatric complication such as delirium and development of ICU acquired weakness. However, emerging evidence suggests that the risk of ICU acquired weakness may be mitigated by lower steroid dosages, better glycemic control, and reduced sedation. Thus, the appropriate steroid dosage balancing the therapeutic benefit with this potential adverse effect is crucial. So, the treatment guideline for CIRSE 2017 and B. So, CIRSE in septic shock, which is unresponsive to the fluid and vasopressor, medication is IV hydrocortisone, that is less than 400 mg per day for 3 days. Then, CIRSE in early moderate to severe ARDS, we can give methylprednisolone 1 mg per kg per day. In community acquired pneumonia, hydrocortisone should be given by as less than 400 mg per day for 5 to 7 days. And as a generalized approach, 60 mg per day divided into 40 mg bolus in morning and 20 mg bolus in the evening. Thank you guys.